Hello, everyone. Professor Nicola Ralph is my name, and I'm delighted to be talking to you today at this Menarini-sponsored GMED virtual event. Today, we're going to be discussing acne and its varying presentations in a global pandemic of the last year. I am a consultant dermatologist and co-founder of the Institute of Dermatologists in Ireland. I specialize in both medical and surgical dermatology and also cosmetic dermatology. So the topics for discussion today include acne and rosacea and some of the newer treatments that are hopefully in the pipeline, as over the last few decades, we haven't had very many new treatments. We're also going to discuss Maskne, which has been an entity around for essentially decades, which is a form of acne mechanica. However, as you all be aware, particularly those who are frontline workers and working behind PPE for many, many hours a day, Maskne is becoming increasingly frequent in the last year. I'm also going to discuss Acne Cosmetica because this is something that I'm seeing very, very frequently in my clinic. And then at the end of the talk, we'll have time for questions and answers. So to start with acne, it's a multifactorial disorder of the pilosebaceous unit and has both a significant psychological and economic impact on those affected. It roughly affects 9.4% of the global population. And unfortunately, for some patients, it's not only physically debilitating, but also emotionally debilitating. It is clinically characterized by comedones, which is the primary lesion, and they may be open, so that's the blackhead, or those closed comedones, which are those tiny little bumps under the skin surface. The inflammatory lesions include the papules and the pustules, and for some poor individuals, the deeper cystic lesions or nodules, which can unfortunately lead to scarring. The clinical picture varies significantly from person to person, from mild comedonal acne to fulminant acne fulminans. It's primarily a disorder of adolescence, and as we all know, we've all suffered with spots at some point, but it roughly affects over 80 to 85% of teenagers. However, increasingly seen in our clinics and also in the literature, adults, but particularly adult females, are reporting flares of acne into their 40s, with roughly 20 to 40% being affected on a regular basis. So particularly in the Western world, rosacea is often described as adult onset acne by a lot of our patients who think they are suffering with acne, when really this isn't a true acne and is another condition by itself. We call in Ireland rosacea the curse of the Celts, as it roughly affects 10% of the adult population, and the average age of onset is the 30s to 40s. Again, just like acne, it's characterized by the inflammatory papules and pustules, but mainly of the central face. And they also report this background erythema due to the broken capillaries, and patients will report easy flushing, particularly with temperature change or if they're anxious or nervous. They'll often describe trigger by UV radiation, hot food or beverages, alcohol, and a change in environment. And we're moving in the recent years to describe rosacea in terms of its subtype or phenotype. The most common that we would see in clinic will be the erythematotelangiectatic or papulopustular rosacea. Some patients will report dry or gritty eyes or recurrent blepharitis, which is ocular rosacea. Phimosis rosacea is more central face with thickening of the skin, particularly on the nose. And more increasingly, I'm seeing a lot of neurogenic rosacea in my clinic. So to discuss treatment for acne, first-line treatments for mild acne include the comedonal type of acne pattern, which really would be a topical retinoid. For those who also have papulopustular lesions, you may consider adding a topical retinoid with a combination topical antimicrobial. And again, for those with more severe papulopustular lesions, you may also add in an antimicrobial agent. Studies in the recent years have shown that the average duration of antibiotics before treatment with isotretinoin is 331 days. And we all know that we're becoming more conscious in recent years of trying to not overuse antimicrobials. There are some new anti-acne therapies in the pipeline. We've all been familiar with the regular tetracyclines such as limacycline, minocycline, and doxycycline. However, there is a new agent, sarecycline, which is currently undergoing studies, and hopefully this may be a new agent to treat both acne and rosacea. It will hopefully also have a more narrow spectrum, but be highly active against Cutibacterium acnes, Strep pyogenes, and Staphylococcus aureus. So this is also going to be a once daily treatment, which will make it convenient to take for patients. For our female patients, we also have the option of the oral contraceptive pill or spironolactone, but as we all know, these are temporary measures to fix acne and will suppress acne as opposed to curing acne. We may also do comedone extraction for those with significant number of comedones, And for those with more severe acne, which may be scarring, or those who have failed all other treatments, isotretinoin is the treatment of choice. Historically, we all use isotretinoin approximately to doses of 120 milligrams per kilogram, cumulative over roughly a 6 to 7 month period. However, what we're seeing from studies is that there are higher rates of relapse, and it is now recommended to treat people either for lower dose for longer or to make sure that they have a greater cumulative dose. In the most recent studies, it has shown that there's a 10% relapse rate at doses of a 10% relapse rate at doses of over 140 milligram per kilogram cumulative. But for those patients who are treated with a less dose, such as 70 milligrams per kilogram cumulative, the relapse rate is 20%. So the guidelines would now say that we should aim to target of treating patients to greater than 220 milligrams per kilogram rather than less than this to prevent relapse. The etiology of rosacea is also multifactorial, just like acne. Initial erythema may be the start of an inflammatory continuum initiated by neurovascular dysregulation and the innate immune response. There's marked increase in mast cells at the interface between the nervous system and the vascular system, and we all know that UV damage is implicated. As we know, the human microbiome consists of millions of organisms, but Demodex folliculorum has been implicated. But interestingly, in studies, it has shown that Demodex brevis is actually more common in those with mild rosacea and Demodex folliculorum in those with moderate to severe rosacea. This is a mite that lives harmlessly on the skin, but in many people who have rosacea, higher numbers are found. Again, there have been links between metabolic syndrome and rosacea, and what we know is that patients who have higher blood sugars or blood glucose levels may have increased infestation with the mite, and they may also be at increased risk of hypertension, hypercholesterolemia, hypoglycemia, and hypertriglyceridemia, but there isn't an increased risk of ischemic heart disease, cardiovascular accident, or diabetes mellitus. There's also this abnormal immune reaction in the skin due to the presence of certain bacteria and mites, which may lead to the inflammation that we see on the skin surface, and genetics may also be involved. The exacerbating factors that patients will report include extremes of temperature, such as excessive heat, alcohol, stress, UV radiation, spicy food, and hot beverages. So this has led to a new treatment algorithm developed by a consensus group in the recent years, which really leads us on to describing the rosacea phenotype and treating what we see in front of us. So for those with transient erythema, you may consider topical adrenergics, but as we all know, this just suppresses the erythema temporarily for a number of hours. For those who have more persistent erythema due to the broken capillaries, they may want to consider IPL or intense pulse light. For those with mild, moderate, or severe inflammatory rosacea, you may want to start with topical agents such as azelaic acid, topical ivermectin or metronidazole, and just to note that azelaic acid is safe during pregnancy. And those with more severe inflammatory disease may need to consider oral doxycycline. In studies, it has shown that the low dose doxycycline, 40 milligrams, is superior to placebo and non-inferior to 100 milligrams of doxycycline. However, in my hands, I really feel that I don't have the same response when I give patients low dose doxycycline, so I haven't recently used it, and I only use the 100 milligrams daily dosing. For some patients who have ocular rosacea, the low modified release dose does seem to be effective, but again, if they have more severe blepharitis, you may need to increase to the 100 milligram daily dosing. Again, for those who fail all of the topical therapies and the oral tetracyclines, you may need to consider oral isotretinoin. These patients tend to only need lower dose treatment rather than the higher doses that you may need to achieve to treat acne vulgaris. However, this is an off-license indication for the management of rosacea. Again, for ocular rosacea, which can be very debilitating for some patients, lid hygiene is really important with warm compresses, meibomian gland expression, dilute baby shampoo, and lubricating drops. And for those with more moderate to severe disease, you may need to use oral doxycycline either at the lower modified release dose or at the higher dose. An interesting case study from the American Academy in the recent months showed that the topical use of ivermectin on closed eyelids can have a significant improvement on moderate to severe blepharitis. So moving on to acne mechanica, this is due to secondary chronic friction from helmets or straps, where you see these well-defined lichenified hyperpigmented plaques with some comedones underneath. And this linear geometric distribution is suggestive. So obviously the treatment is to eliminate the cause, but we have seen an increasing incidence of this in the last year. We have now entitled it Maskne due to this COVID-induced entity that we're seeing. What we're seeing in our patients is superficial papules and pustules along the jawline, chin, lower cheeks, and the neck. And it's due to the tight fitting mask, particularly those who are behind PPE for prolonged periods of time. And this friction is stimulating sebum production from the oil glands. Then you have this humidity that we all know we can feel behind the mask when we wear it regularly, which creates this perfect microenvironment for bacterial growth. And obviously for those who reuse the mask, which shouldn't be done, this can exacerbate the condition due to the buildup of oil, dead skin cells, and bacteria behind the mask. The treatment, I advise my patients to do a nightly double cleanse, firstly with micellar water to emulsify any makeup, oil, or SPF that's been used, a cream cleanser for my adult patients who may have more sensitive skin, and a foaming gel cleanser for my teenage patients who tend to have oilier skin. Advising them to pat the skin dry rather than rub it to reduce any friction, and nightly introduction of products containing alpha hydroxy acids or beta hydroxy acids such as lactic, glycolic, or salicylic acid. And if their skin is too dry, to add a moisturizer also before bedtime. Again, each morning I advise them to use moisturizer to prevent further friction on the skin surface and to create a barrier between the skin and the mask. Also advise them where possible to use oil-free makeup and sunscreen, and to try and have makeup-free days under the mask. You can also add in skin actives such as retinoids at night, and a lot of companies are adding niacinamide to their products for its anti-inflammatory effect on the skin. Acne Excoriée is an entity that I'm seeing increasingly in the last number of months. It tends to be young women who have papules and comedones but are neurotically scratching or excoriating them. You see these erosions with these linear scars, and unfortunately the same treatment doesn't apply with the oral antimicrobials or topical agents which may have drying agents in them, as this can exacerbate their condition. So I've had great success in the last few months with cognitive behavior therapy with some of my female patients. Acne Cosmetica is not a new entity. It's due to chemically induced blocking of the pilosebaceous orifice. It was first noticed in the 1970s, but has improved by changing ingredients within products. However, there has been a resurgence since 2020, and I really feel that this is due to social media influence. If you are followers of Instagram or TikTok, you'll see that lots of people are posting complicated skincare routines that take 30 minutes with 10 layers of products every night before bed, which really is too many skin actives at one time and too many layers of products. So really this is down to social media influence in the last year. Some of these trends that we've seen during this pandemic include slugging and sunscreen contouring. And I actually saw an example of this in my clinic recently, whereby a patient on an oral tetracycline who had been advised not to get sun exposure due to its risk of having sunburn, put highlighter onto the areas that you see here where the patient wants to have highlighted skin or contoured skin, and puts the sunscreen onto the paler area to create this effect. However, unfortunately, due to the fact the patient was using tetracycline, had a significant sunburn by not wearing their sunscreen. Another trend that we've been seeing on TikTok is slugging, which involves smearing of a thick layer of petrolatum on the face, leaving it on overnight. And ideally, for those who have atopic dermatitis, this may be a great treatment. However, unfortunately, for my patients who have tried it with oily-prone, teenage acne-prone skin, they have developed these tiny little papules under the skin surface with significant congestion. So again, to bring patients back to basic, to try and get them to avoid overusing skincare products, just basic cleanse and moisturize, stop the use of excessive oils and excessive skin actives, and to use their broad spectrum, particularly if they're on retinoids or oral antimicrobials or isotretinoin. But really, we are the newer generation. Everyone wants this instantaneous generation, and to try and emphasize to patients that unfortunately skin takes time and they're not going to see results in 1 to 2 days. So thank you for your attention, and I'm happy to take questions.